Dobrodošli. I would like to say you welcome to this Keynote session. I think that it will be very interesting about best practices on the management of present pain in children and adolescents. Minna Stahl is our presenter, and Zala will tell us who Minna is.
Yes, I'm very proud to present Dr. Minna Stahl. She's a PRM physician. She's specialized in pain management. She did her PhD about nonspecific neck pain in children and adolescents. She's the head of the Finnish Center for Children and Adolescent Pain Management and Research. She is also the Finnish ambassador in European Society of ESPRM, and she's a co-chair in CISC for PRM in children. She is also a Finnish delegate in UMS PRM section and board. Please, Minna, give us your talk.
Thank you, Zala, and good morning to everyone. It's wonderful to see at least this many of you after yesterday's great party. And many of you were already in this morning listening our case presentations about this topic. So today I will tell you more general things, but thank you also for Katja for inviting me. I have heard that this is actually the first time that this type of topic is on an EACD Congress, so it's really remarkable. Thank you. So why I'm here today, I think there is a great need to raise awareness of this pediatric persistent pain. Professor Ecclestone from UK, who is really a father of this pediatric pain management, he has said that disabling persistent and recurrent pain in children and adolescents is under-recognized and under-treated even in the hospital settings around the world. That's awful. So hopefully after my lecture, we are aware of this type of problem as well. So I thought I will introduce a little bit about the concept of pain, just for you all to get level to this subject. So how do we understand the pain today? We used to be, no, it doesn't work, okay. Okay, so anyway, we used to be quite long time, we used to have this impression that, and knowledge that under pain, behind the pain, there always needs to be something wrong in the body where the pain is felt. Well, it's the red ascending system, somatosensory system that reacts for heat and for injury and for inflammatory things in the body, and this is the ascending system we have. So it's nociceptic pain usually, but after functional MRI brain imaging, we have started to understand that. Thank you. That there is another system as well. No, I don't see that. Okay, well, never mind. So there is actually our brain is like a computer all the time adjusting to these ascending messages. So there is a descending pathway that is modulating the ascending signals continuously in the spine and in our brain. And so actually pain is always an individual experience, so nobody can question whether someone has pain if he says that he is painful. So this is number one, never question about whether your patient has pain or doesn't have it. Pain is always in your brain, even though it feels in the toe. It always has a neurobiological background. Such thing as psychological pain doesn't exist. Pain can arise also without an actual tissue damage as a result of central sensitization. So it's called nociplastic pain then. It means that the signaling in your body has altered. And you get a pain experience from something that before wasn't painful experience for yourself. And there is a great evidence of this central sensitization from these neuroimaging studies. They show altered resting brain network connectivity, changes in brain gray matter in pain processing regions, neurochemical imbalances, and immune system abnormalities in persons with central sensitization. Okay, now we go to this persistent pain. Persistent pain, it's usually called chronic, but it has a really good prognosis in children. So I have just excluded this chronic pain. I call it persistent pain. It's pain that has lasted more than 3 months or is recurrent. It doesn't have to be all the time there. And then in EACD-11 classification, we can divide pain into primary pain and secondary pain. I believe this secondary pain is more familiar to all of us. For example, yesterday we were talking about CP children. They have certainly a lot of this secondary pain. There is always a cause, underlying cause. It's an injury or a disease that can be detected in medical investigations. So always a pathology behind. And the pain mechanism is usually nociceptic or neuropathic, where there is an injury or permanent functioning problem in the neurotic system. But this primary pain is less understood. There is no pathology found in the organ where the pain is perceived. But if we would imagine the brain, take the functional MRI from the brain, it shows these changes. So it really is there. It's a biomechanical origin. Pain is the leading symptom, but they also have fatigue, sleep difficulties, even fever. And so pain mechanism is this nociplastic. The body has become sensitized to pain. And examples are local or amplified musculoskeletal pains, complex regional pain syndrome, juvenile fibromyalgia, irritable bowel syndrome with pain, or even chronic migraine. And pain in children and adolescents, it can be divided to the secondary pain or primary pain things, or also, of course, there are the procedural pain, which is a nociceptive origin as well. But actually, often these, in primary pain, there is falsely diagnosed mechanical pain. So mechanical pain in the joints, if it's local joint pain in the lower extremities or in spine, it's very often still mechanical origin, even though it has lasted more than 3 months. And nociplastic pain, you need to have a multi-professional approach. But for mechanical pain, you just need very sophisticated physiotherapy that is aimed to this mechanical problem. It's called manipulation. It can be manipulation of the fascia or joints or muscle, fascia, and joints. So be aware if there's a localized pain, then in the musculoskeletal system, it's not necessarily this nociplastic origin, even though it has lasted for a long time. But very often we see mixed pain. So there can be secondary cause, for example, rheumatoid arthritis, and then the body becomes sensitized, so there is a primary pain condition in addition. And then let's see about the epidemiology of this persistent primary pain in children. It's common already in school-age children. Our patients, the youngest patients are 5-6-year-olds. Headache, stomachache, musculoskeletal pain, they are about as common all. And then about half of them have this amplified or widespread pain. And prevalence increases with age. As you see from the prevalence rates, they vary a lot. It's very much more common among girls than boys. And this type of persistent primary pain has become increasingly prevalent among school-age children. And here are some trends from 1991 to 2017 from this large Finnish population-based study. We asked neck pain and back pain, and then we combined those who had both neck and back pain. And if you see here is 12 to 14-year-old girls, neck pain, single neck pain is more common, far more common than back pain. But what's alarming is the increase in this multi-site spinal pain. And this is even more prevalent if you look at a little older. So 16 to 18-year-old girls, 30% have persistent type neck pain, 5% persistent back pain, but the trend for multi-site spinal pain has increased 2 to 3-fold during these 30 years of follow-up. And this is alarming because this persistent pain in adolescents predicts chronic pain, disability, unemployment, psychological distress, psychiatric comorbidities, and excessive use of health services in young adults. So these become really expensive in future to us if we don't do something when they are younger. So what are the association comorbidities for these primary pain syndromes? There are potentially traumatic events that associate with this type of pain. Many of them have had school bullying experiences, perfectionism. They have high demands in school and sport performances. They usually, very often have also learning difficulties. They have a lot of school absence and dropouts, sleep disturbances, psychiatric comorbidities such as mood and eating disorders, and neuropsychiatric comorbidities. So if you look at this list, it's quite worrying, I think. And here is a nice study from Germany. So where should we treat these children? And if you look about, there is, the highmost is 5%. So 5% of this population is severely disabled. 5%, that's quite a lot, I think. And these are children that would need tertiary care, specialized pain clinic care. But in reality, what happens for these type of children and pain? This is a nice study from the United States. They checked 6 years back how many physicians they had met, how many therapies they had gone through, how many medications they have tried, how many aids they have had, how many operations and procedures they have had. So it's a cumulative figure, and this is so normal that you meet this type of family or patient, and then you don't know, there is nothing wrong, then you send it to the next one, let's try that one, let's try that one, let's try that one, and still after 6 years there is a situation that the child is painful, and also doctors feel really helpless. So it's time to say something about the best practices. I have quite a long history of treating these patients myself. I have gone through a lot of literature since I have been establishing this pain clinic to Helsinki. And then there is a really nice guideline on this from WHO. So first of all, these children with disabling primary pain condition, or it can be also combined with secondary pain, they should be treated and assessed and treated by healthcare providers who are skilled and experience in evaluation, diagnosis, and management of persistent pain. So there is a childpain.org internet page that you can have a look at these pain centers. They are actually not too many at all in the world. But I was so happy to hear this morning, some of you said where you were from, and so there are more than this map shows. And there are several associations, at least here in Europe, that are providing these specialization programs for doctors, for psychologists, for physiotherapists, occupational therapists. So it's possible to sort of specialize in this matter too. And children with persistent pain and their families and caregivers must be cared for from a psychosocial perspective. Pain should not be assessed or treated simply as a biomedical problem. And this is unfortunately not the case in many hospitals yet. So we need a multi-professional team, for example, that is consisting at least from physician that is specialized in pain management. It can be physical and rehabilitation medicine specialists, anesthesiologists, pediatricians, child neurologists, or many different backgrounds. We need nurse, we need psychologists and physiotherapists who are specialists into pain management. But this is usually not enough, but this is at least what you can start with. Usually we need occupational therapists, nutritional therapists, social worker, rehabilitation counselor, and creative art team, especially those children that have neuropsychiatric comorbidities. They don't get well by only physiotherapy or psychological interventions. They don't even want that usually. They don't feel it's right. But these creative art therapies are good alternative with occupational therapy to these children that are the most difficult to treat, I think. Then the care should promote the engagement and support children and their families to play really active role in caretaking, and we should inform them and discuss with them. There always needs to be a goal that is born from the family. If you set the goal as a professional team, it doesn't matter. It doesn't work. It needs to be driven from the family. And the team, it's not good that there is a physiotherapist working there and then a psychologist there and a doctor there and maybe social worker there, and the family goes to one place and then gets that advice and that. Really, we need an interdisciplinary way of working. It needs a team that is working in the same place, interacting daily. So we have daily team meetings to discuss about the progress of patients in order to find the right therapeutic window for different interventions. For instance, usually the families are not open to psychology a visit in the first meeting, but it will open up while the rehabilitation program goes on. So it's a waste of time, waste of energy, and really frustrating if you offer something that you think they need, but they are not willing to take yet. So timely interventions are really important. This needs adequate time. They're really time-consuming, these patients. And you need a good space where the whole team can meet the families. So this is not something you do bedside in the hospitals. And so, for example, our visit to the first visit is 90 to 120 minutes, 2 hours, and we meet the whole team meets the family in the first time. We need a comprehensive assessment. So, family situation and history of chronic pain, pain itself and other symptoms, pain interference in daily living, sleep, school, sports, social life, comorbidities, previous treatments and their response, pain catastrophizing and beliefs, also from the parents, pain-related fear avoidance, and of course, thorough clinical examination for pain phenotyping. We need to know whether it's nociceptic, nociplastic, or neuropathic in origin in order to tackle it from the right angle. What and to who this pain-related disability belongs to, or how do I say? Because there can be one family with a child with severe pain and there is no disability. She goes to school, she still sleeps well, and goes to see her friends. And the other family, they just stay at home. They don't interact, they stop going to school. So, of course, there is the painful condition, but earlier experiences, feelings, thoughts, environment that are affecting our brain. And there are these two characteristics. First of all, there is the pain catastrophizing. So it means that the parents or the child thinks that pain is a sign of something that is seriously wrong with me or with the child, even though all the examinations show normal. So this leads to extreme worrying, which enhances sleep problems, anxiety, depression, and of course this all increases all symptoms because you're hypervigilant. And then there is this other characteristic, which is kinesiophobia, so fear of movement. I cannot use my body because it hurts. It means that I need to rest. So this leads to physical deconditioning. So when you have these two, there is a severe pain-related disability. So of course, we have to tackle those things first in order to proceed. So this is a fear avoidance model that we use a lot in educating the family. So there is the pain experiences, and when you're really worried about the pain and you are worried about moving yourself, your whole life narrows so that finally, and when you worry, you get more symptoms. When you worry more, you get more symptoms, and then you don't sleep, and you're all the time anxious, and you have lost your friends, the school, and everything. Of course, you become depressed. So this is a vicious cycle. And so to get better, we have to understand what the pain is all about, and then go for this slowly progressing, going back to the normal life, and without fear, and then the recovery happens. And the goal setting is really important, and it needs to be an ICF framework, so that the goal must be to gradually restore the normal life despite the pain. Persistent primary pain is not a sign of an injury or disease. It is safe to use your body. This is really important message you have to deliver. And we pick goals in sleeping, going back to school, going back to sports, going back to social life gradually. It is really important to ask the child, what is your goal? What are you missing because of the pain? What would you like to have back in your life? Of course, we need multimodal treatment, and it needs to be tailored to the needs and desire of child, family, and caregivers. And of course, available resources. The aim is to retrain the brain to sense things normally again, to calm the central sensitization. And you can do that by doing this psychological interventions. You can take medication, you can go to physio. All these affect to your brain, and then they calm the central sensitization. So there must be a range of different individual therapies that you can offer because, as I said, families are different. You have to start from one thing and then proceed to the next thing. Group therapies, family therapies are also essential to be offered because they need peer support. Really, that's these kids, they think that they are the only ones. And if you see the prevalence rate, that's really common actually. But people don't talk about pain. Pharmacological interventions, they are second-line therapies. So first, go for these non-pharmacological interventions. Usually they work and you don't even need the medication. If there is a severe sleeping problem, I usually start medication. Or if there is really bad hyperalgesia or allodynia, then I also start medication in the first visit. And I use tricyclic antidepressants and gabapentinoids, but absolutely no, never, ever opiates. Remember that, no opiates. And here is how it looks the whole. So there is a huge team that is a huge network of different professionals. And then there is the core team, and the core team has, each of us, we have a certain role, but we co-work so that we assess individually and the whole family, and then we do a plan and we do continuous assessments. And the doctor's job is the pain phenotyping and looking for the comorbidities and overall functioning and educating first time about this pain. And then the child goes to physiotherapist, nurse. We continue the pain education similar way in every room. It is really important you did it similar way. And then, of course, we all have different things we do. So psychologists, they work with the pain catastrophizing and fear avoidance thing and mood, sleep disorders, and then physio with physical functioning, fear of movement, body tension, and so on. But the most important thing to remember from this slide is the pain education. It needs to be continuous and done similar way. So, what are the characteristics of this typical case? A girl that is in teenager years, very ambitious in school or in sports or both, has a history of school bullying. It can be a few years back, but it's there. Mother has chronic pain. There has been one pain, and it has become multi-site or amplified. It has developed to sleep difficulties. The child is complaining about nausea, dizziness, anxiety, fear. Extensive investigations show all normal findings, but there has been a lot before you meet. NSAIDs and paracetamol does not relieve at all. It doesn't work. They are peripheral, designed for nociceptive pain, and they don't work at all for nociplastic pain. Findings on the clinical examination is usually hypoalgesia or allodynia, at least in the painful area, but it can be in the whole body. There's a strong belief that the doctors have missed something. Parents, they don't know about this type of pain. And fear of pain and movement, and this is a cause of disability. This is very typical case. So how could we recognize these patients as early as possible? I'm sure many of you meet these patients, but how to sort of recognize them very early so to tackle this problem before it becomes a problem with disability? So there is a pediatric pain screening tool that could be used. There are 9 questions. How am I doing time-wise? Hello? Sala? How am I doing time-wise? What time is it?
You have 15 minutes.
15? Okay, I have been really quick.
10 maybe. 10.
Yeah, okay. So pediatric pain screening tool is created by Laura Simmons and her team. She's a clinical psychologist from the United States. And it's really clever. This could be adapted to any clinic, like an orthopedic clinic or rheumatoid arthritis or child rheumatology clinic, so that they could detect these patients as early as possible and then consult the pain team. So my pain is more than in one body part. That is, if it's widespread, then you get a point. I can only walk a short distance because of my pain. It is difficult for me to be at school all day. It is difficult for me to fall asleep and stay asleep at night. It is really safe. It's really not safe for me to be physically active. I worry about my pain a lot. I feel that my pain is terrible and it's never going to get any better. In general, I don't have as much fun as I used to, and overall, how much pain has been a problem in the last 2 weeks. So if you get a certain amount of points in this, then it would be a cutoff to referral to the pain center. Yeah, I've been really quick. So, to take home message, persistent disabling multi-site primary pain in childhood and adolescence is an increasing health problem with poor natural cause. But persistent pain in childhood and adolescence has an excellent prognosis. 80% of our patients in my clinic, they have cured with normal functioning. When treated in family-centered psychosocial framework in the specialized unit. So, we need to make pain matter. We need to make pain visible. Especially, we need to make pain understood, pain education. That makes pain better. And then I have a few minutes left, so I can maybe tell you a little bit about my work, what I do. And this is a really special case. The Finnish Center for Children and Adolescent Pain Management and Research was established only 3 years ago to Helsinki. This is the largest leading university children's hospital in Finland. And there was really a great unmet need in pediatric health services for these type of pain, complex pain syndromes. So this would happen. They went to one doctor to another one, and everybody, all the doctors, they said, "Oh, I don't want to take care of this. No, oh, this is awful. I don't understand. Oh, nothing helps." So they were really frustrated. But that's what you do if you have 20 minutes or half an hour time to meet these type of patients. You really have to have time to sit down, listen, explain, do the goal setting together. So, yes, too little time and not knowledge enough. That makes things frustrating. So this interdisciplinary pain clinic with research activities was established with the great donation money. So we got 2.7 million euros from a foundation in order to build our clinic in 3 years. And now that we're in the end of these 3 years, we have established a team of 12 multidisciplinary members, and we all are specialized to pain management. And now that the clinical setting is set up, so we have an outpatient clinic with pain rehabilitation. We have 200 new referrals yearly at least we have had now. Let's see how the future is. And the length of our treatment varies from 2 months till 3 years. And then we also have a consultative pain services for hospitalized children with difficult acute, post-acute or cancer pain, and to children that are in palliative or hospice care. So we have tried to tackle this whole pain field from one unit. And we have actually succeeded quite well. And now we are ready to be part of the normal hospital system. So from the beginning of June, we will be just regular service, and also government is covering our costs. So this would be a really good idea for some of you if you are missing this type of clinic to sort of try to find the foundation money to beginning and then make a deal with the hospital. And what we're doing, we're not only establishing our own clinic, but we're doing a national model of pain management for children in Finland. The way that, no, they are not referred to our center. We are a national center, but it doesn't work. This persistent pain children, they cannot come from all over the Finland to our team to be cared, because the rehabilitation needs to be taken place in their daily living environment. So we need to educate different teams working different parts of Finland, and we have succeeded so far. There are 6 other teams now working in different parts of Finland, and we have monthly meetings and educational program for these teams. And I have been visiting the Nordic countries. All the Nordic countries, there is a great need of this type of thing in North, and I believe also maybe in Europe too, maybe in the world. So actually there is this good try to unite our way of working and also doing research. There is a project starting from next September that got financial support from the European Union to build such a network. And we're part of that, and maybe some of you are part of that too. I don't know. Anyway, I want to thank you once again coming to listen this thing that is really close to my heart. And when you have time and when you have skills and when you have team around you, this is actually really fun work. This is not at all frustrating or tough or whatever. So it's like any other job in the hospital. And if you're interested in further contact, or if you want to promote this type of activities in your country, please, I will be so glad to help you in building something similar. So email me. It would be my great honor to help you with that. Thank you very much.
So thank you, Minna, for this excellent lecture and sharing all your knowledge with us. I'm sure there are some comments, questions. We have a few minutes. Okay, so then I'll ask you something.
There is one.
Oh, sorry. Yes, please.
Alain Châtelain from Paris. You told us about pain leading to disability, but my experience asking young people with cerebral palsy about their concerns, their first concern was not walking or speaking or participation. Their first concern was pain. So my question is, how many of your patients or young patients come as disabled patients, and what is your experience of pain in cerebral palsy or other conditions?
Yes, in Finland, cerebral palsy is taken, and rehabilitation is taken care of much by child neurologists. And we have child neurologists in our team who is especially taking care of these cerebral palsy patients. And they have, usually cerebral palsy patients, they have a secondary cause of their pain, but sometimes they have also this primary type of pain. And these, of course, this type of pain education, and that doesn't always work for children, and especially if they have cognitive problems. So the how to deal with these patients that have some other major disability reason behind, and also pain there, it's a little bit different. It's more medically oriented, I think, but the parents need education. And yesterday we learned that, for example, feeding and all these physiotherapeutical interventions, they are really quite often painful. So we would need to think with the caregivers and therapists, how could we in the future do this less painfully? So to use, for example, distraction. I don't know if I don't have experience, but does any one of you have experience of using VR when you do, for example, standing practices for cerebral palsy children, to use VR distraction at the same time? That's what we are bringing now in to our hospital, to different clinics. We haven't started yet the neurology department, but that would be an option. So to think more widely about those situations where the cerebral palsy patients experience the pain. They don't have that type of primary pain, as I was concentrating in my lecture today, so much. It's more this nociceptic type of pain, in my experience. But it's repeated daily.
Okay, thank you. Any other comments, questions? Okay, so I think our time is up. Thank you, Minna.